So healthcare loves consensus because it feels responsible. But some of the worst decisions in healthcare happen when organizations prioritize agreement over outcomes. Hi, I'm Bruce Spurlock, a physician and healthcare leader committed to helping professionals and decision makers navigate change with clarity. On viral healthcare, we look at the ideas spreading across healthcare and what it takes to implement them wisely and sustainably. So today we're going to talk a little bit about when do you involve others and what does it mean to involve others in the decision-making process when you're considering these new trends, new ideas, innovations, platforms, all the stuff we've been talking about for the past several weeks. What does it mean to make decisions by yourself, or what does it mean to make large consensus-driven decisions as we've gone on? Now, if you've been a healthcare leader for several years, I suspect, I really probably can predict accurately that you've been burned by a decision that failed, by something you decided to go with. Maybe you had a group that went along with you that said, this is an important thing for my organization to do, but it failed because it didn't include a critical perspective. And you're going, man, the next time something like this happens, I'm not going to ignore that critical perspective. And it might have been somebody from the front line or an end user type perspective that really caused it. I've had several of these in my own life. We didn't include nursing or the frontline nursing, or we didn't include therapy, or we didn't include the laboratory, or we didn't include some component of the organization that was really critical. And the default for us in those kind of situations is to overcorrect, to be more inclusive, to avoid making that error again. And this idea that if we get broad buy-in, I hate that word. I don't think it actually describes it. I think it really is a fake word that hides what really happens and how decisions and innovations are adopted in an organization or adopted across a large group of people. But that's what people say we need to have before we get started. Now think about it for a second. What would happen if Apple in the iPhone or even some of these AI companies said, we're going to wait to launch until we get 60+% of the customers to buy in? I mean, it's just crazy. They don't behave like that. So why do we do that in healthcare? Well, there are good intentions behind consensus. I mean, it's not that we're not thinking about it. The whole idea is like before we launch, we need to build broad agreement first. So why do we like that so much? What is it about broad agreement that sounds, so appealing, so attractive? What happens when one person makes a decision or everyone has a voice? I mean, everyone having a voice is sort of had this status in not only healthcare, but in our society that we've really, really thought this thing through and really been consensus and collaborative driven. So collaboration is like that. There's these words that people use like stakeholder alignment. What if we went through a process where this committee reviewed it and then that committee reviewed it and that committee reviewed it? I had one of those when I was back practicing in medicine, and it was sort of like the forms committee. And they actually had like 17 different forms committee to change one field. I guess that's good, but obviously you can see the downsides from that. There's this idea that if we get broad participation, or this word I've used a lot, inclusivity, if it's inclusive rather than exclusive. Exclusive sounds like we're elite, sounds like we know better than everybody else. And those are things that don't really go well in healthcare. Now, they're good instincts. They're things that we should be cautious about. I mean, healthcare should not be an authoritarian type setting. And there's a lot of evidence and research that's suggesting that solo decision-making has its weaknesses. Collaboration is useful. I do most of my work in collaborative type environments when people can share ideas, but we're not often in collaboration using that for deciding whether our organization should be adopting a new practice, a new field, going into a new major decision like a new market or those kind of things. Different perspectives matter, and understanding those perspectives matter. And we have sort of this rich history of collaboration in healthcare because it's social. I mean, it affects social conditions and it affects populations. We think about that. And so being social, it's easy to want to fall into that. Let's do something that includes all of the voices that happen. Now, I want to stop for a second and take a digression. I know sometimes as a leader, you don't really want something to pass. You want it to die. And consensus is one of the greatest ways to make something die. So you can send it to multiple committees. And this is where we talked about the forms committee. You can send something to the forms committee to die just because, getting that many different people to agree is really, really challenging. Sometimes nowadays we'd probably calling, let's put it in the IT queue for them to fix with the electronic health record or something else in IT. But it might be something that we deliberately think about. That's not what we're talking about today. We're not talking about deliberately trying to tank a decision. We're talking about when we really want to be thoughtful about it. So when does collaboration become over collaboration? So this is when consensus stops being a tool and becomes sort of the default operating model, or so how we do things here. And everyone needs this concept called buy-in. That's this rallying cry that has this buy-in. I don't even know how to measure buy-in. I don't even know what people really know. Like, I know it when I see it. It's kind of like love. I think that this idea of buy-in is really what I use engagement as the term. And engagement doesn't happen like instantaneously. It doesn't happen all at once. It has to grow over time. And sometimes waiting for that is a real problem. We can't move forward unless anybody agrees, or more alignment means better decisions. You ever heard that one? The best decisions are when we have this complete alignment. And again, don't get me wrong. Not having alignment is a problem with some of these things. So we got to be cautious about that. So what happens when we overcorrect and overdo collaboration and consensus development is we stop optimizing for the best decision and start optimizing for the least uncomfortable one. Think about that for a second. Yeah, am I going for comfort or am I going for the best decision? So here's one of the things I want to talk about with consensus in particular, because I've used this, and sometimes consensus is the only way to keep an organization together over the long haul. I actually do that with one of the ones we work with right now, and it's really critical. It's part of the reason why we've been in existence now, coming up on 20 years. But my definition of consensus is the answer to the question, can you live with it? And in real consensus, in my experience, when you really have diverse opinions, everyone leaves unhappy. It's suboptimal for everyone. Everyone has to give up a little bit of what they think is optimal to get to that question, can you live with it? That's not broad agreement. That's a very different kind of phenomenon. And in fact, it leaves a bad taste. Everybody has a sour stomach when they leave within a decision that, yeah, I can live with it. It's just not optimal. What mostly people talk about consensus or collaboration or groupthink is that it's about minimizing the discomfort, about getting this broad agreement, and it slows everything down. It can be useful and it can be deadly from a decision-making process standpoint. So when you get into groups, doesn't matter the size of the group, there are always these hidden dynamics going on. And this is the problem when you get more than a couple of people involved with the decision making. There are social dynamics. So who's friends with who's kids play on the same soccer team, who play on the opposite soccer team. There are political pressures, sort of, I got to keep this group involved because they're critical to the structure of organizations. Sometimes organizations talk about that with physician organizations. We need to keep this physician organization because they're politically and market-based important. There are status differences, right? There are people that are in the executive suite and people on the front line, and that gives some status hierarchies that go on. It also happens with professionals as well. There's this fear of disagreement. Like, we don't want tension. We want harmony. And in fact, we've talked about this in other places. Amy Edmondson's talked about psychological safety. And in psychological safety, you often do have tension because people can actually speak up and disagree publicly, which creates tension. When you don't have that tension, it probably means harmony means suppressing certain voices. So it shapes which ideas get voiced, which risks get ignored, which concerns stay hidden, and how quickly we can get rid of dissent. It's all about sort of minimizing dissent. And it turns out dissent in a decision-making process, as we talked about a couple of episodes ago, is critical. We're going to talk about that a little bit more in a future show as well. So how does this show up in healthcare decisions? I mentioned some of these already. Endless committees and a committee process where there are toll gates, or there's a strategic plan, but nobody owns it because everybody has to approve it. So if everybody has to approve it, nobody really has to own it. I mean, you might get a champion or somebody who's facilitating, driving it, but it requires incredible persistence. And that's part of the shiny object phenomena. I mean, you can't keep going on it, even if it is a good decision, even if it is a good activity to adopt and to innovate and go into. So it's just this innovation that everyone supports, but nobody drives. And it's safe decisions instead of effective decisions. So the decisions look great externally. They might have great presentations. They sound good. The messaging sounds really alive. The PowerPoints look great. Everyone leaves the meeting feeling included, but the data suggests that these are some of the worst decisions in healthcare. In fact, there's a broad amount of literature that it actually slows down uncomfortably to a point where people lose momentum and they make different decisions. So accountability gets diffused, operational clarity disappears, and the trade-offs really never get addressed. The hard trade-offs we've talked about before. So the question you need to start thinking about is moving from how do we get everybody comfortable to what actually produces the best outcome. It's subtle, but super powerful to get away from disagreement being a bad thing. Disagreement is obviously less desirable. We'd all love to have agreement, broad agreement, but broad agreement in the stake of worse outcomes is really not the way we should be moving to it. So don't let consensus be political cover because nobody will really own it in that kind of a situation. Now, there is an example where maybe let's call it authoritarian, or I call it solo leadership decision making is really critical. And we've spent a little bit of time. We're going to do some more about that in a future episode when the decision needs to be made quickly, when time and urgency is paramount, when decisions can be reversed easily if you can course correct really rapidly, and when there's experience or special knowledge involved that you have to act quickly. You need to have these individual leadership decisions or rapid response decision making. A good example in healthcare is cybersecurity breach. Trying to get broad consensus, organizing a group, putting everybody together, listening to all the input, the hour or two that can happen with that could be deadly. Or an active shooter situation. We know in healthcare, a couple of those have happened, and trying to let's decide how to make this happen in that kind of a setting. If you're a surgeon or you're in the emergency department and you have a trauma case, asking everybody in the room, what should we do next, is probably not optimal. Somebody needs to be decisive. Somebody needs to be making decisions that we can evaluate and reverse if we have to do it. So most healthcare decisions are not true emergencies. And yet organizations often either move too slowly through consensus, and we've talked about how long and slow it can take, or they move too quickly without enough dissent. So dissent is this critical piece. It's really important to think about it. The real sweet spot for most decisions in healthcare are small, perspective, diverse groups. We're going to spend an entire episode talking about how to assemble and put those groups together, where I've seen them work, where the literature says they don't work, or the problems with it. But I'll go over a couple of things to think about. The biggest problem for most CEOs or executives making decisions is that they can be shielded from honest feedback. I mean, it's weird, but this notion of there's a sycophant, somebody that tells you what you want to hear, is really prevalent. And why is that? Well, it's because people, want to keep in your favor. They want to demonstrate that they're smart, like you're smart, then they value, they have respect for you. They think that maybe they would be punished or that they would face consequences for doing it. Or maybe people are just uncomfortable with confrontation. That's just the way they were raised, that I'm an anti-confrontation type person. So CEOs being shielded from honest feedback is real danger. The makeup of the decision-making team is critical. Who participates, when and why and how, who you leave out. Because ultimately, at some point, you're going to be exclusive when you have a smaller group. It's just the nature of it. And thinking about exclusivity, not just for that episode, but for future episodes, is also an important part of it. And then you have to have active mechanisms for dissent. You just can't do even small groups without structured formal ones. We've talked about a little bit this before. We mentioned the pre-mortem. In fact, we're going to take a deep dive into premortem in a couple of episodes, talking about how to do it well. Another one that you can do is anonymous pre-polling. So you can have people write down on their first meeting, you present your topic of what you're thinking about, and they can generate ideas, and that gets dissent that's rewarded. Or you can actually put a structure like the red team, or we've talked about the devil's advocate, where somebody plays the role of trying to widen your perspective, trying to include new ideas and arguments against why you might be successful. So here's a key point for today's episode. There's been a lot of research in governance and decision-making process, and some in healthcare, especially around hospital governance. And what has been found is that organizations tend to use consensus methodologies for strategic decisions and not operational definitions. Exactly the opposite of what is optimal. There are a few times when getting broad consensus around operations, the things that dramatically affect the front lines and that are values, and not really about decisions, but sort of how things get orchestrated in an organization, more about learning and organizational structure than adopting a new practice and idea. Those are the operational decisions when broad consensus making, and that's exactly when we do just the opposite. And so that's kind of the lesson from today, is that's healthcare's legacy, is to think about consensus from a strategic standpoint and not an operational standpoint, and it's just the opposite. All right, so next episode, we're going to take time to dive deep into a national viral trend in healthcare that I was deeply involved with. And we're going to look at what survived and what didn't survive. And you're going to hear me do a little bit of a mea culpa on the next episode. So the next time you're in a major meeting or a strategic decision-making process, ask yourself, are we trying to make the best decision or the most comfortable one? Now, if you have ideas or would like to participate in this, send me your thoughts. If you have an example of a trend, or if you have an example of we did a decision perfectly well, or we had crisis and major catastrophe after a decision, I'd love to hear some of those as well. We want to give more examples of real life things, and you're part of the solution to that. I want to thank you for listening to Viral Healthcare. If this conversation was useful, share with a colleague who's navigating change. And if you'd like more thoughtful conversations about ideas shaping healthcare, be sure to follow the show. We're here every Tuesday morning at 9 a.m. Pacific. We'll see you the next time. And I'm Bruce Spurlock, and having a great time.